Hello and welcome to TLC Academy. My name is Alan Sousie and I'm interested today in giving you facts about what causes a person to have a stroke. And I intend to give you kind of a basis for this, as well as some of the indicators to look for and to recognize a stroke when it occurs, and ultimately hopefully give you some ideas on how to help someone who suffers from the experience of a stroke. So let me begin by asking a couple of questions, because today there's a lot of talk about cholesterol and how cholesterol is a part of someone's experience of having a stroke. A couple of questions about cholesterol are these. Does cholesterol cause strokes? And are there some types of cholesterol that are actually beneficial, not harmful? Why do we get high cholesterol in the first place? So I want to start by giving you a definition of what cholesterol is. Cholesterol is a unit of fat. It's known as a lipid, and it's also a protein called lipoprotein. We have lots of this in our body. It floats around in our blood. It ends up going through our liver and other places. And it's actually produced in the liver. Even if we didn't get cholesterol through our food, we would still have lipoprotein in our bodies because of our liver producing it. What is the role of cholesterol in our lives? Well, it helps to make the outer coating of all of our cells. It produces bile, and bile helps us to actually digest fat. And it enables the body to make vitamin D and hormones like estrogen in women and testosterone in men. Certain conditions in our society contribute to a surplus of cholesterol. Conditions such as foods that we sell in our stores that are high in saturated and trans fats, foods that have too much refined salt and sugar, and the basic sedentary life that a lot of us live now that we are tied to devices and less athletic than we used to be in some cases. Smoking is still a very significant part of our lives, and unfortunately, even though it has been reduced over the last few years, there's still a lot of people that have taken it up, and unfortunately have taken it up in the form of this new type of digital devices used for smoking. Excessive alcohol consumption also contributes to the problem of high cholesterol. Some other situations which are not due to lifestyle are that men have a higher blood pressure and at an earlier age than women do, and women have earlier menopause than men do. There are two types of lipoproteins. First of all, we have high density lipoproteins. That's commonly referred to as HDL. It takes fats back to the liver either to be processed or expelled from our body. The higher your HDL, the better for you. Then we have low density lipoproteins, which are called LDL. These don't go back to the liver. They settle in our arteries, our veins, and our capillaries and form a plaque. LDL should be the lowest number of the two rather than the highest, to avoid this clogging of our arteries, veins, and capillaries. Our body converts some unused fat into triglycerides, which are stored in fat cells. And when the body needs energy, guess what? These triglycerides release into the bloodstream and give energy to our cells. This is particularly true if you fasted in any way through the course of the day. Triglycerides also break down alcohol in our body. Triglycerides as well as LDLs definitely contribute to a waxy plaque along the lining of our blood vessels. This waxy plaque shrinks the width of our arteries and thereby restricts the blood flow, causing high blood pressure or hypertension to occur. Now, one of the most significant functions of our circulatory system are the arteries. Importance of our internal carotid arteries is this. They are blood vessels that carry blood to the brain. When plaque builds in a carotid artery, which is the ones along the side of your neck, or in any other part of the body, you have what's known as atherosclerosis, or in layman's terms, hardening of your arteries. When there's enough buildup of plaque on a blood vessel wall, it erupts and it tears away. This is called a thrombus. Thrombi restrict blood flow within the blood vessel, and it slows down and possibly even stops blood and thereby oxygen from getting to your cells in the body. Blood that cannot get through a vessel coagulates and builds up around a thrombus. Blood clots are what these are referred to as. And blood clots, obviously, like the thrombus, limit the flow of blood, especially if it's blocking the carotid artery, which goes to your brain. When this happens, needless to say, brain cells are going to die because they don't get any oxygen or any nutrients. What we call this is a cerebral vascular accident or a stroke. Around 50% of all strokes are caused by the plaque buildup in internal carotid arteries. The rest of the strokes are caused by heart problems and aneurysms. In this paper, I'm going to simply present some of the symptoms of a stroke and when to call 911. Some of these are permanent, some of these are temporary changes in the body, and they will occur inevitably and often require rehabilitation. And I also want to speak a little bit to you today about how to prevent strokes. So let's start out with symptoms of a stroke. How do you know what you're looking for and when to call 911? The American Heart Association uses an acronym called FAST, F-A-S-T. F stands for look at the person's face. See if the mouth appears crooked. A stands for arm. See if an arm is hanging in a limp position. S stands for speech. Ask the person a question. Listen to hear if speech is slurred or mumbled. And T stands for time. Time to phone 911 if any of these conditions are found present. So what are some of the warning signs of a stroke? It is helpful to notice the time symptoms occurred. Sudden numbness or weakness in face, arm, or leg, especially on one side of the body. Sudden confusion, trouble speaking or understanding conversation. Having sudden trouble seeing in one or both of your eyes. Having sudden dizziness when you're walking, or walking itself becomes hazardous. You lose your balance. Your coordination doesn't follow when you need to use it. And sudden severe headaches without a known cause can also be indicative of stroke warning signs. So what kind of strokes result from these CVAs, cerebral vascular accidents? Well, we have what's known as a paretic stroke, which is paresis is a stroke that does not leave a client totally immobile, but somewhat mobile. That is, usually a limb is affected, a single limb is affected, or a part of the body only is affected. Transient ischemic attacks are mini strokes lasting anywhere from 2 minutes to 24 hours. Symptoms resemble a stroke, but they do subside usually, and appearance and function usually return to normal within a few minutes or maybe within a few hours. TIAs often preclude a more significant stroke, meaning look out because something bigger may be coming later. Then we have left and right brain strokes. A stroke on the left side of your brain leaves the right side of the body paralyzed, what we call right hemiplegia. A stroke on the right side of the brain leaves the left side of the body paralyzed, or we have left hemiplegia. Left brain strokes affect speech and behavior. About 1/4 of all stroke survivors do have a language impairment. This includes speaking, writing and understanding both spoken and written word. This is called aphasia. When one has expressive aphasia, it's a limited ability to speak and to write and to use correct grammar. The part of the brain causing expressive aphasia is called the Broca center. The Broca center. And that's located in the front of your brain. Receptive aphasia affects comprehension of what is being said or written and may affect coherency of your speech. Brain damage causing receptive aphasia occurs in the Wernicke's center toward the rear of your brain. And then finally we have global aphasia, involving both the Broca and the Wernicke centers, and therefore affects almost all of your written and your oral communication. Help with aphasia can be provided. When you help someone with aphasia, cues are typically used to help recall words. As an example, the client says, "We went to a restaurant last night, but I can't remember the name." The client's son gives first cue. "Think of a fruit, Dad." The second cue. "Think of a fruit we picked off trees, Dad." The third cue. "Think of a fruit we bake in pies, Dad." And the client says, "Oh yeah, apples." Client says, "Yes, we went to Applebee's restaurant." Repeating sentences that someone else has said also improves vocabulary recall. If cues, memory techniques, and other exercises are not effective in restoring speech, then try symbol boards or sign language. And even computer programs today make it helpful and are possible to use. As far as personality is concerned, left-brained stroke survivors are more cautious, anxious, and slower to do things than they previously were. The right-brain strokes result in perceptual difficulty. This includes distinguishing up from down and left from right. Everything sort of seems tilted to that person, to the person with right brain stroke. A stroke victim may have problems using a wheelchair, setting things down, or walking from place to place, especially if they're on an incline. Regarding personality change, the person will be more impulsive and make decisions more quickly with little forethought when they have a right brain injury, and it will take them a lot longer to learn new things. Now, what are some other symptoms seen in clients in either left or right brain damages? First of all, there's an inability to use ordinary objects, like a knife or a pen. The affected person knows what the object is, but there is a disconnect between knowing the object and being able to pick it up and make it useful. This is due to the brain damage and not a result of any kind of paralysis, even if paralysis is present. Then there's hemianopsia. That's a long word. But what it means is the affected person is only able to see out of half of his or her eye. If the paralysis is on the right side, then the person will be unable to see out of the right side of both eyes. Then another type is chronic pain as a result of strokes. The thalamus of the brain processes sensations from the body to the brain. If your thalamus has been damaged due to the stroke, it tends to send false signals of pain to the body. This is referred to as thalamic pain syndrome. Not very pleasant for anybody suffering stroke. Bad enough to be half paralyzed, not able to talk, but then to have the pain on top of it makes it even more challenging. And what is also pertinent to a caregiver is the person may not always be able to tell you that they're having pain. So you may be needing to look and spend more time trying to figure out when the person is in pain and what are some of the signs that you look for that are physical. Maybe body language is going to be more important than words. Another significant symptom that we see is unilateral neglect This means that one side of the body is paralyzed, and the affected leg may literally like slide off from a footrest or drop off the side of the bed if the person happens to be lying in bed. And they don't even know that the leg has moved. They lose the feeling and sensation in that body. Or if their upper extremity is paralyzed, they might find themselves lying on it for long periods of time and not even know that they're lying on their arm. It's just lost to them. So unilateral neglect is a very significant problem sometimes for causing breakdown of skin or causing circulatory issues. Another problem is numbness, tingling or prickling of an affected limb. Needless to say, this can be really irritating to someone consistently over time. Again, another issue and symptom is thinking and memory problems. The affected person may have a shorter attention span, short-term memory loss, loss of the ability to make their plans, and certainly a loss to learn something new. The inability to plan the steps of a task and carry it out in a sequence, we refer to medically as apraxia. Emotional liability is an issue for people with strokes. What does that mean? Well, if you have emotional lability, you tend to exaggerate your feelings. Individuals laugh or cry out loud for no reason whatsoever. They just suddenly are laughing or suddenly crying. They appear to have little or no control over the outburst, and they often are embarrassed by such spontaneous displays of their emotion. These can occur anywhere, under any circumstance, and very much unexpectedly. However, there are emotional disturbances which are secondary to a stroke that are longer lasting. Emotional disturbances are one of the most common side effects. And the challenge for the person is they don't know what the future holds. They often are despaired by what the future presents for them in the way of their ability to do things or to live life. They become filled with fear. They have lots of anxiety. They get very frustrated quickly because normal reactions that they would typically have are affected by the brain's damage caused by the stroke, and therefore they can't discern how to manage those feelings appropriately. Sometimes the emotional reactions and personality changes are misunderstood by people around the person who suffers the stroke. And unfortunately, too, sometimes stroke victims begin to express and show the clear signs of clinical depression. And this is very common in the emotional disturbance list of people with strokes. They typically are on an antidepressant fairly soon in the process, because physicians have come to realize that for stroke victims, the depression is very much real and very much a part of their daily living. Some of the survivors of strokes become quite despondent, however, and they may weep repeatedly without ability to control the weeping. And they could go on for very long periods of time. As a caregiver, how to help them and comfort them becomes a challenge, because your patients may become thin, and unfortunately you don't want that to happen, so you're going to try your best to keep your patients and give as much emotional support as you can in a gentle, calm way. A couple of other problems that people with strokes face have to do with the bodily functions of controlling our bladder and controlling our bowels. Urinary incontinence is usually present, or can be often present, due to the loss of sensation in the bladder's capacity status. Can't feel how full your bladder is. The affected person does not experience any urge to urinate. That's another issue. Many times these stroke victims end up with an internal catheter, even if it's a temporary catheter. In the beginning, to help them to remain clean and hygienically sound, the catheter is a tool. Doesn't mean in the long term that they can't learn to reuse their bladder muscles and gain back some of the sensation. Sometimes they can. but that's a process of recovery. Then there's bowel incontinence. In the same way, bowel incontinence does result from loss of peristalsis, which is the action within your bowels of moving stool through the bowel. It's like little fingers in there that are moving the ball along. And this is an involuntary constriction of the bowel that pushes it along as well. And when this doesn't occur, then you can get terrible episodes of constipation that can occur. And so the constipation has to be treated effectively and has to be considered immediately upon the arrival of the stroke situation. A lot of times nursing staff will typically offer a bowel and bladder program where caregivers strongly suggest to a client to have a routine trip to a toilet, even if the trip is not effective when you do it. Just getting them into the habit of going to the bathroom and trying often will result in a better control of bowel and bladder. And it helps to facilitate the retraining of the bowel and the bladder. So after a while, you will see improvement, but it takes time. And then the last significant symptom, side effect, if you will, after effect of a stroke, is trouble swallowing, what's known as dysphasia. Dysphasia is caused by a number of different variables, such as a lack of ability to chew. The facial muscles might be paralyzed. There's a delayed swallowing reflex, and sometimes people pocket food, which builds up between teeth and cheek instead of being swallowed. Imaging machines may help diagnose the underlying cause of dysphagia as they record the swallowing process. Dysphagia may be abated by simple things such as changing a person's posture so that they're sitting more upright, pureeing their foods to soften them and make them more palatable. Thickening liquids may be necessary so that they can swallow. I point out from my experience, one of the worst liquids to be able to swallow when you have a swallowing dysphagia is water, even though water is one of the most important liquids we can put in our body. The good news is the thickening agents that are used usually have no taste effect on whatever beverage it's being used with. So explore that, and there are some home remedies that can be used to thicken foods, which are also available readily online and in other resources. But I bring that to your attention today because thickening liquids is a very common practice that caregivers may encounter in their care of someone who has had a stroke. And lastly, the suggestion to the client to eat slowly, small bites, chew well, take the time to swallow all of the bolus of food before taking another bite are the cue types that you would use to help someone with a stroke. Okay, let's move on and talk a little bit about bedbound persons. Because oftentimes people with strokes become bedbound or wheelchair bound or both. When a person is bedbound, one of the most significant things that happens is bed sores and shearing of skin are common. And this can happen for any person, no matter how young or old. The affected person needs to be repositioned often. We recommend every 2 to 3 hours. And sometimes a protective barrier cream, lotion, or an ointment can be applied to bony prominences like the occipital area of the back of the head, the hips, the elbows, the shoulders, the knees, the ankles, your heels, and coccyx. And when moving a client up in bed, it's best to use a draw sheet, a cotton blanket, or some type of cloth underpad, which will draw the person to the head of the bed rather than drag the person to the head of the bed. And using a draw sheet can be a movement in bed can be accomplished by only one person, depending on where you position yourself in relation to the client. But commonly, draw sheets are used by 2 people. as a mobility technique. Any of the tools named will help prevent shearing of skin on the buttocks or the coccyx, which are where most of the tears occur or the wounds occur. Another common problem with people who are bedbound is foot drop. If this is left unattended, you will see a significant loss of the ability for a person to recover ability to ambulate. Dorsiflex muscles are relaxed for long periods of time when foot drop falls. What happens is they don't get used. And if you don't put some type of a support at the foot of the bed so that you keep the foot in flexed position so that it can't drop like this forward, then as long as it's up, it's being flexed, the muscle stays taut. If it drops, it becomes loose and flabby and therefore loses its functionality, and the person eventually can't do this anymore with their foot. So a foot rest, a foot guard, a foot drop guard, is sometimes like a board that's made out of simple wood or plastic that sits at the bottom of the bed and the foot just rests against it. So very important to do exercises with the person's foot to keep the flexibility and to keep the use of the muscle functioning. That's called passive range of motion, and also to use a footboard whenever it's available to do so. Another very common side effect of bedbound people is pneumonia. Pneumonia is an ever-present complication for bedbound individuals. Routinely, if you raise the head of the bed and turn the client from side to side, this will help prevent pneumonia from setting in. Encouraging the bedbound person to practice deep breathing exercises several times a day can also help prevent pneumonia. And commonly, someone coming home from a hospital after a stroke will come home with a breathing device, a respiratometer it's called, or something to that effect. And you blow into it, a little ball goes up to a certain level, and they can actually see it and know that they've achieved their goal, and then when they stop breathing for a minute, it drops back down. That's a tool that is commonly given to patients who are discharged from the hospital after a stroke. All right, so what about another type of result of strokes is just plain immobility of a person. What happens to immobile people is they get contracture of their joints and they often get blood clots. The contracture of joints results from immobility when the pain and stiffness of joints gets excessive. People don't want to move. If, for an example, if an arm is in a sling, which limits the arm's use, pain might radiate out from your shoulder. This pain is caused by tendons and joints that are fixed in one position for too long. Lack of movement causes a joint to contract or freeze up. Contractures are essentially muscle or tendon that has remained too tight for too long, and therefore they become shorter in their length. Contractures or freezing can be minimized by doing simple range of motion or following some type of exercise program that's given by a therapist. Now, what about blood clots? Well, again, immobility gets even more complicated by the development of venous stasis, meaning blood flow from the veins is diminished or becomes non-existent. This is caused primarily by the lack of muscular exertion in an extremity. If a leg sits too long without being moved, or an arm sits too long without being used, the muscles sit quietly and do nothing. So there's no movement to exert pressure on the veins to help push the blood back to the heart. Blood clots are determined to be present if they are determined to be present in people's legs, never elevate the legs, because the clots could break loose and move through the system to the lungs, causing a pulmonary emboli. Persons with blood clots often are prescribed blood thinners, but some of these drugs have to be carefully supervised because they affect you so severely, and medical procedure requires that routine blood tests are done. Blood thinners also are identified as possible precursors to brain aneurysms or aneurysms in other parts of the circulatory system. Unfortunately, an aneurysm can end your life. These are often very fatal because it's literally a blowing out and an explosion of a blood vessel. So all of a sudden there's this huge amount of blood that's being poured out of the body. So what about mobility for clients who are stroke victims? How do you transfer a client from a bed to a chair? Stroke-affected individuals may be permitted to transfer from a bed to a chair. It's essential to remember to always have the person pivot toward his or her unaffected side and to use the unaffected arm and hand to reach the arm of a wheelchair, a commode, or whatever other seat they're moving to. The point there is simply lead to the strong side. Bring the weak side along with the lead of the strong side. Now, how do we prevent strokes in the first place? That's the last part of what we're going to talk about. One way certainly is to lower your cholesterol and triglyceride levels. As I mentioned earlier, there is little we can do to avoid some risk factors associated with high cholesterol because of genetics, our gender, and sometimes early menopause. But there are factors we can do to lower cholesterol and triglyceride levels. First, remember to get cholesterol, blood pressure, and triglyceride levels assessed every so often. If your cholesterol, triglyceride, or blood pressure is high, you may be prescribed appropriate medication. But changes to your diet and increasing your exercise are often beneficial as well. We are encouraged to eat meals that are low in animal fat, especially from meat. Moderation is key to successful reduction of your cholesterol. One may also try to eat complex carbohydrates as opposed to sweet refined sugar. Some examples of these complex carbohydrates are beans, nuts, peas, various fruits, whole grains such as brown rice, whole wheat, oat, and cereal grains. A diet to lower triglycerides is very similar. Get rid of the refined sugar, limit your alcohol intake as well. How about eating omega fatty acids? Is it good or bad for the heart? Well, according to the experts, they're good for the heart. Two of the fatty acids are EPA and DHA, which are found abundantly in fish and in fish oil. And so people with high blood pressure and cholesterolemia are encouraged to consume fish at least twice a week. Those with high triglyceride levels might also take fish oil as a supplement, either the oil itself, liquid form, or in capsules. Other chemicals that lower triglyceride levels are niacin and fibrates. All right, what about sodium? How does that affect us in terms of all of this? Well, it affects us significantly. Unfortunately, sodium is found in just about everything we eat. Doesn't matter whether it's sweet or not. There's salt in most everything. Avoiding salt requires your constant attention to product labels, and removing salt from your table is probably wise. No added salt is necessary for the most part with almost any food that we purchase in the grocery store. Sodium reduction simply means getting consumption as low as possible. You do not have to eliminate salt entirely. Lower is better. Sodium is actually an essential electrolyte of our body, which helps to regulate the saturation level of all of our cells and our tissues. So it is positive to have sodium in our body. It also works cooperatively with potassium in our body to help regulate our heart. And when we keep a balance with other electrolytes, sodium contributes to the body's proper function and to the overall well-being of ourselves. Some tangible sources where you will find sodium or salt are monosodium glutamate, food preservatives, artificial flavorings that are added, food coloring sometimes have it, and then high fructose corn syrup and smoked and processed meats are also loaded with it. What about diet soda? Should we avoid it? Well, some are more dangerous than others. The uncertainty about whether it's dangerous or not remains still to this day. But according to the American Stroke Association, one diet soda a day could potentially increase your risk of stroke by 48%. What about vitamin D? Does that help in any way? Well, according to the experts again, if you have an increased risk, if you have low levels of vitamin D, you will have an increased risk of hardened arteries and double the risk of stroke in most Caucasian men and women. So, importantly, consider taking vitamin D supplements, or spend a whole lot of time out in the sunshine and get the same effect. Smoking clearly is something you should eliminate, because if you do smoke, quit. Birth control pills may increase risk of blood clots, strokes, and heart attacks. If you have to use them, be conscientious of this. If you don't need them, don't use them. And last, exercise, exercise, exercise. You will lower your cholesterol by exercising 5 times a week, even if it's only for 10 or 15 minutes or 20 minutes. You don't have to be a star athlete in order to exercise 5 times a week. Take a walk. Get off your couch and take a walk. So the conclusion, I have attempted to outline possible causes of stroke, how to avoid a stroke in the first place, and what a caregiver can do to help someone in a post-stroke condition. If you take to heart, being a stroke victim does not have to be part of the future. So thank you again for listening today.